Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with Evan and Josh. How are you guys doing?
Good. Glad to be here.
Same. Thanks for inviting me.
Yeah, absolutely no problems. And the reason why I got both of you here today is I'd really like to talk about paralytics with vent management. And, can I do good vent management without the use of paralytics is ultimately what I'd like to get into. But to start off with, let's go over what paralytics are and kind of the basic background information.
Okay. I'll just jump in. So paralytics, or we also talk about neuromuscular blockade. We're talking about basically paralyzing the patient just like it sounds, but I think it's important to differentiate that from sedation or analgesia. So when you give a patient a paralytic, they cannot move. And among other things, you paralyze their respiratory drive, you paralyze many of their reflexes, including their airway reflex. You can, in some cases, make the patient easier to work with for things like intubation or surgical procedures, but the patient loses all of their respiratory drive. However, with just a paralytic on board, the patient is also typically fully conscious unless there's something else working on them. So a patient can be paralyzed but completely awake, which is a terrifying situation. So that's kind of what they do. Any y'all have anything to add to that?
I would add that I think it's important to name the distinction between paralytic and neuromuscular blockade, because you can give a subtherapeutic dose of one of these neuromuscular blockading agents and your patient will be weak, but not paralyzed.
Good point, Josh.
And so patients can still interact with the ventilator while they're on a neuromuscular blockading agent.
Okay. Yeah. I mean, what are the common paralytics that we would use in DOD?
So some of the ones that you're going to run across are succinylcholine and rocuronium are probably the most commonly used in EMS systems and emergency departments for rapid sequence intubation. They're favored because of rapidity of onset. And then you've also got vecuronium and cisaferine, or CIS as it's called. And Josh will talk more about that because I don't use that much in the emergency department. And those are longer duration agents. Vecuronium is the one that many medics have in their aid bags without their battalion surgeons knowing about, because it's the only one of these that's completely shelf-stable and reconstitutable. The only other one that has any sort of degree of shelf stability is rocuronium, which can potentially be held at room temperature for, depending on what the label says, maybe up to a couple of months, 90 days or so. Otherwise, they're typically requiring refrigeration. So that kind of gives you the lay of the land on those. Succinylcholine and rocuronium, you're going to be about a 45 seconds to a minute at the typical doses we're using these days for onset of action for rapid sequence intubation. Succinylcholine is going to be a lot shorter duration. It's only going to give you about maybe 10, 15 minutes of action, whereas rocuronium will give you maybe half hour, 45 minutes of duration of paralysis. And then the other big thing to note about succinylcholine is it's the only one that we've mentioned that's a depolarizing agent. So you're going to get those fasciculations when you intubate. You're going to know that you've got intubating conditions because the patient's going to have that sort of little weird twitchy wiggle thing that lets you know that they are good to go. And then vecuronium, 2 to 4 minutes is a typical onset. And then you're going to get 40, 60 minutes out of that. And then something similar for CIS.
So as other than just, duration of effect, is there any reason to pick one over the other?
Well, for RSI, mostly, like I said, we want the onset time to be fast. So for the most part, folks favor drugs like succinylcholine and rocuronium because they're faster in onset than the others. So, when you want to take an airway, you don't want to have a whole lot of time while you're waiting for that paralysis to take effect. Now, ER docs argue endlessly about sucks versus rock, and it's many papers and podcasts have been devoted to that, and that's kind of beyond the scope. For our purposes, probably the most practical difference would be that shelf stability. Almost everything else, you'll hear some folks talk about the potassium issue with succinylcholine because there is a transient elevation in potassium. So for style points, if you have a situation like a crush injury where you're concerned about hyperkalemia, succinylcholine would be theoretically the less cool option. However, there hasn't been a study yet that has actually demonstrated a change in what happens to the patients because of this transient 0.5 increase. And there have been a lot of people who were paralyzed with succinylcholine and then later found out to be hyperkalemic. So whether it actually matters to the patient, we don't know, but for style points, if you think their K is up, usually rock would be the better choice.
Okay. Other than just RSI, is there any other common use for paralytics?
Yeah, I think the only other common indication in medicine is for patients with severe acute respiratory distress syndrome who have significant patient ventilator dyssynchrony. And so the patient's not comfortable on the vent and is overbreathing frequently. And so we can use neuromuscular blockade to improve vent synchrony, which may decrease ventilator-induced lung injury. Our drug of choice in the ICU for that is cisatracurium because it doesn't accumulate in renal or hepatic failure.
Okay.
The only other thing that I can think of where it's commonly used, I mean, it is used in the OR. The anesthesiologist will use it while they have a patient in the surgical plane because it will prevent the patient from having jerks, either basically their reaction or due to like electrical bovie. It decreases their responsiveness during surgery. So anesthesiologists will use it to maintain a surgical patient, but that's kind of outside of my scope, certainly. So,
understood. Now you mentioned, Josh, patients in the ICU, ARDS, different ventilatory modes of, different ventilatory modes being used. Is it considered kind of standard of practice, or maybe even the gold standard, to have your patient paralyzed? While you're doing vent management?
I would say it's far from the gold standard if we're just talking about every patient.
Right.
Internationally, probably in 2005, an international cohort study found that 13% of patients in the ICU were on neuromuscular blockade. And the incidence of ARDS is much lower now, and so that number is also probably lower because the only patients we use this on are patients with severe ARDS.
Okay.
So uncommon and far from the gold standard.
Okay. So if that's not the standard of care, then what is standard of care in order to maintain this patient on a vent?
I think you should use a tiered approach to patient ventilator synchrony, to making a patient comfortable on the ventilator. Start with optimizing your ventilator settings to match the patient's demands. Match the patient's respiratory rate and try to match the patient's inspiratory flow rate, which you can do on most full function ventilators. And then you would move to an analgesia first strategy with bolus dosing first. And so if your patient is uncomfortable with the ventilator, there are two things about the ventilator that are uncomfortable to an awake patient. One, if the patient is intubated, is the sensation of the tube going through the vocal cords, stimulating the gag reflex. And then two is the sensation of a positive pressure breath, of somebody breathing into your lungs for you rather than you expanding your thorax and taking a breath. And so you treat that with pain. Start with opioids, bolus dosing first. If bolus dosing is inadequate, or you don't have the nursing ability to give every 30 minute to 1 hour boluses, then you can start an infusion. And then after you have an analgesic infusion running, so fentanyl or hydromorphone infusion, then you can add a sedative medication if you still have significant patient discomfort. And when I say sedative, I'm speaking of propofol would be the most common. You could add ketamine if you're not carrying propofol.
Okay. So you had mentioned fentanyl. You just mentioned ketamine. Now, as far as a dissociative, would you be adding? Could I use, say, ketamine as as the analgesic, and you work in like a Versed or something like that?
You could. Ketamine is not a great ventilator tolerance drug because it doesn't decrease your respiratory drive in the way that opiates do.
Okay.
And then benzodiazepines like midazolam or Versed are certainly good at reducing the respiratory drive and improving patient ventilator synchrony. We avoid them in the intensive care unit because they make outcomes much worse. Patients who are on benzodiazepines stay on the ventilator for longer and stay in the ICU for longer. But if that's all you have, then that's certainly a reasonable way to get ventilator synchrony.
Okay. Now you mentioned analgesia first, which is also part of our analgesia sedation CPG. I guess, what are you looking for in once you've gotten the patient some kind of airway, you've gotten them on the vent, when you're walking this analgesia in, I guess, what exactly are you looking for?
So our nurses will use validated scoring systems to determine both agitation and also pain in the ICU. And it's important to acknowledge that first, prolonged field care is austere critical care, right? Mm-hmm. And then critical care is delivered by critical care nurses and critical care physicians and respiratory therapists and the whole team. And the special forces or special operations forces medic in a prolonged field care environment is both the critical care nurse and the critical care doctor. And so should be able to assess the RASS, which I've heard mentioned on this podcast before, the Richmond Agitation Sedation Scale, and should also be familiar with the CPOT scale, which is a validated critical care pain observation tool. And so you're looking for respiratory rate, facial expressions, grimace, and coming up with points, which you're recording over time, just like vital signs, to determine how much pain your patient is in.
Okay. And then so you mentioned a RASS scale. I've definitely heard of the CPOC score, but I'm definitely not super used to using it to what I'm in what I'm doing now. I guess, what are you targeting as far as a RASS scale when you're walking your analgesic in, but before you've added your sedative?
Our default is a RASS of 0 to -1. So the patient is easily arousable and comfortable. Maybe eyes closed when you walk in the room, but opens to voice or opens to a hand on the chest.
Okay. And that's while they're being vented, obviously,
yes.
Right? Okay.
Yeah.
Okay. And then once you get them to that, 0 or -1, when you want to start adding your sedation, I guess, what are you now taking them to? A -2 or?
Only increasing sedation if they have ongoing ventilator intolerance.
Okay.
Or
dysynchrony.
Or like agitation, delirium, synchrony. Yeah.
Okay. Okay.
And so if we have ventilator intolerance with a higher RASS, and we target a low RASS, -2, -3.
Now, all of what you said sounds great, and I'm on board. However, when I try and do these things, okay, I get my patient, I give them their airway, I start getting them ventilated. Usually I start off with a BVM and try and get a feel for things. And I'm trying to build myself a buffer because I know I'm going to screw it up the vent. So I try and get their oxygen as high as I can, end tidal CO2 under control. And I look at that save 2 and I try to transfer the settings, I guess, with the BVM as far as like PEEP, rate, volume, etc., the best I can onto the save 2. And then, obviously I get that set up. I go through the checks. Everything's good. As soon as I connect the patient to the vent, it immediately starts to alarm and craziness starts to ensue. I'm using the settings that are told to me that I need to use. I'm using, my knowledge to the best of its ability. Granted, there's not much knowledge, but I'm using it to the best I can. What the frick am I doing wrong?
First, let's acknowledge that you are selling yourself short and you don't need to do that. And then allow me to relieve you of the burden of thinking that you are doing something wrong. And let's blame the ventilator itself. If I may, I'll quote from the COVID-19 clinical practice guideline, of which you are an author. And it lists a series of ventilators And then it lists the SAVE 2, and it says, if this is the only device available at your location, you should arrange transfer as soon as possible. The SAVE 2 vent is not capable of caring for a sick patient for a prolonged period of time. And I know that the SAVE 2 vent study is quoted on Prolonged Field Care. And I know the authors, they're from my institution, and I talked to them about doing this podcast. And he's like, you're not using that vent in the field, are you? I'm like, yes, we have been. He's like, you're not using that vent on patients with poor lung compliance, are you? And I'm like, well, hopefully not. That study demonstrated that the SAVE 2 vent could oxygenate and ventilate heavily sedated animal models for 1 hour. Mm-hmm. 1 hour does not count as prolonged field care, and so it's not what we should be using as our goal. We can start talking about the inadequacies of the SAVE 2 if you want to.
I got a great big SD card, so fire away.
So it's flow limited to 24 liters per minute. You and I, when we're just doing normal breathing, are taking inspiratory flow closer to 30 to 40 liters per minute. And so this then does not deliver high enough flow to support just a normal patient who's not sick and in respiratory distress. It has an 8 liter per minute max minute ventilation. And so while you can adjust the respiratory rate as high as 30 breaths per minute, and you can adjust the tidal volume as high as 1 liter per minute, it will not allow you to get a tidal volume and respiratory rate frequency that is higher than 8 liters per minute. And 8 liters per minute is barely enough to support you or I, healthy patients, on a normal ventilator. It's certainly not going to supply enough minute ventilation for a sick patient on a ventilator, and the patient's going to want more. And then there's no patient trigger on this ventilator. It operates in a mode called continuous mandatory ventilation, which means you set the respiratory rate, and that's the rate that's delivered. A full function ventilator that's available in transport and in the hospital will have a patient inspiratory trigger, and it's a cyst control mode. And so if the patient can generate enough inspiratory flow or pressure, the ventilator will sense that and then will deliver a breath at the patient's request. A reason for patient ventilator synchrony on the SAVE 2 is that the patient wants a breath and generates inspiratory flow, but the ventilator doesn't sense that and doesn't deliver a breath when the patient wants it.
Yeah, I mean, I think in reality we could go on for a very long time about the different issues with the SAVE 2 vent. First off, it's not an actual vent; it's a respirator. I don't know how they got away with calling it a vent. But even the company itself says that this is not a vent. But at the end of the day, it's the one we got, at least right now anyway. I was on the TAC site review. We are putting in new vents, actual vents, and I'm sure it'll be at your doorstep shortly. But in the meantime, what am I going to do? I got this SAVE 2 vent, and it's, my hands. Essentially, that's all there is left.
Well, I think one thing, like just to highlight, getting back to the scenario where you started with, where you're saying, well, I'm doing this and it's not working. And I think highlighting a couple of things that Josh said were, one, you're using it on a patient who would otherwise be awake. You're typically using an agent for sedation that doesn't effectively suppress respiratory drive. So they're still trying to breathe fairly effectively. And then on top of that, you're using a device that is completely non-responsive to patient demand, as opposed to an actual ventilator that will it'll do its best to synchronize up with the patient. So that's why it's going wrong. And then in terms of why, how are you going to make this work? I think the real issue we need to look at is, what is the scenario where we're actually trying to make this work? Because that scenario, that schoolhouse scenario where we're practicing, is not actually necessarily the physiologic situation that we're really potentially would even need this. And that's a pretty rare scenario, that there aren't a lot of cases of our medics managing people in the field on ventilators for prolonged periods of time. And that doesn't mean we shouldn't try to be ready for those types of scenarios. But just understand that this is a pretty specific case, especially if we're mostly focused on trauma and then prolonged field care for trauma. So, I talked a little bit in my airway podcast about there's sort of a couple different reasons why you might need to intubate and put somebody on a ventilator, or do a crike and put somebody on a ventilator. And so, first of all, if you have just a plain maxillofacial trauma issue where you need an airway because you need an airway, and the patient is otherwise, has a reasonable GCS and has the ability to breathe on their own, one of the advantages of a crike is that the patient can continue to breathe on their own. And that's one of the reasons in our training of special operations medics that we emphasize the crike over the RSI approaches. I think a lot of medics have the idea that we are denying them RSI because we doubt their capabilities. And that's not the case. I have no doubt that we could train our special operations medics to effectively manage RSI. The problem is mostly that it's really just not the best thing to do in the kind of environments where guys are working, for one. And then also there's the skills maintenance issue of, intubation is a perishable skill. But honestly, I think that's the more surmountable issue.
Actually,
so,
would you mind? Sorry, Evan.
Yeah, go ahead.
Just a really quick interrupt. I think guys get nervous when it comes to airway, and I'm bridging off to airway since you were talking about it, and wanting to intubate, because I believe, they believe, if they're intubating, let's say, a clinical patient, right? Somebody who's not trauma, who doesn't have, maxillofacial trauma where it's an obvious crike. They want to intubate because they feel like, well, that's the appropriate thing to do. I think if guys knew that regardless of why or what type of patient it was, if they needed an airway, it doesn't really matter as long as they get the airway. That's the main concern. Would you agree with that?
Yeah, and I think that there are specific reasons why a crike is actually preferable in the combat environment or the prolonged field care environment for the vast majority of these cases. Is one, like I said, you can take an airway without involving any ventilatory support. And that's not just important because you're trying to get the patient to tolerate the ventilator, but when you're putting a patient on any kind of positive pressure device, whether it's a BVM or whether it's a SAVE-2 or whether it's an actual ventilator, you're increasing their intrathoracic pressure, which in turn decreases their preload, the amount of blood sort of returning to their heart, which can decrease cardiac output. And if they're in a shock state already, such as a hemorrhagic shock patient from trauma, then you are probably going to make that worse. So positive pressure ventilation tends to make patients in shock more shocky, which is why we tend to have the mantra, resuscitate before you intubate. So when we're dealing with a polytrauma patient, and especially in an austere environment where we don't have level 1 rapid infusers to put endless supplies of blood bank blood into a patient to resuscitate them, and so on and so forth, using an airway management strategy, when you intubate somebody, you have to paralyze them unless you're using some very specific techniques. And that means that you're obligating yourself to positive pressure ventilation. The sedation and the paralysis make that a necessity, particularly the paralysis, obviously. So that's a problem right there. So if we don't need positive pressure in that trauma patient in the field, it's nice not to have to do that. And then on top of that, you have the issues of just the medications themselves. Even the most benign sort of hypnotic agent or sedative can decrease a patient's blood pressure just by virtue of, decreasing their catecholamine response. So basically, it just takes things out of the equation when you're in that field environment. And then on top of that, from a resource utilization standpoint, if you're in any kind of PFC environment, all of those sedative and pain control medications are likely to be gold to you, and you need to use them very sparingly. And committing to run, a full sedation on a patient so that they can tolerate a, endotracheal airway is going to put a huge strain on your resources, and then of course on top of that, the monitoring resources of human eyes and so on. So for all of these reasons, we really, it seems a little bit, crazy to the guy who's got a low GCS. Oh man, I hate to crike that guy. I'm cutting open his neck. It's invasive. And it's invasive, but this is not hospital medicine we're talking about here. This is not EMS, stateside EMS medicine with a short transport time. And that doesn't even take into account the fact that you could paralyze somebody and then, start taking contact and all of that.
Mm-hmm. Yeah, absolutely. And guys are not, I don't know if they're really thinking that far ahead. They're thinking about like, what is going to make this easier for me right now, and not necessarily the 4, 5, 6 steps ahead of that. You have to maintain this. How do you know if you're giving a paralytic? How do you know if he's waking up? How do you know if he's going too deep? I mean, there's whole monitoring devices like the Train of 4 and things like that an OR would use to make sure that they're in the right spot.
And there's almost nothing really. I mean, anesthesiologists have nightmares about the malpractice cases of the patients who have been paralyzed but not sedated. That's a really horrible situation to put somebody in. And that, patients will have measurable rates of PTSD from that experience. There are papers demonstrating that. So it's a pretty profoundly horrible thing to put somebody through. And if you don't have a lot of experience and skill at assessing sedated patients, it's really hard when a patient's still paralyzed to figure out if they're light or not. And none of us in the ER certainly are perfect at it. We do our best, but you got to be really on your toes when the patient, like if you've done an RSI on a patient with rock and they're still paralyzed for a half an hour, making sure that your sedation doesn't get light. You've really got to pay close attention to that because it happens more than we would like. And, I think I remember a recent paper that came out to that effect, that it's actually a little more common in the ER than we would want to admit. And it's something that we need to improve on. Mm-hmm. So if you don't have a lot of experience with sedation, that's just going to even compound the problem.
Right. What would be, if there was the patient for the SAVE 2, what would be the patient for that?
I think the patient, if there was a patient for the SAVE 2, it's basically probably the, very low GCS head injury patient in our idiom, in our world. It's trying to keep the patient alive who, has very little intrinsic respiratory drive and doesn't have any primary pulmonary pathology, is not an RD patient or anything along those lines, but lacks adequate respiratory drive on their own, and that you're trying to maintain them. And that's really, I think that's the only place where I see it both likely working and potentially being beneficial. And even that you're going to have to watch, very, very carefully and maintain, watch your end tidal and all of that good stuff. What do you think, Josh?
Yeah, I tend to agree. I think any patient with actual critical illness is going to need a combination of the SAVE 2 and some hand bag valve masking with the pediatric BVM. I just don't think you're going to be able to support someone with the SAVE 2 alone if they're actually sick.
Now, so mentioning the pediatric BVM, to get good compliance with that BVM, would you essentially use the same strategy you did for the vent as far as analgesia than sedation?
Yeah, and you can use less analgesia than sedation because you can watch for the patient to initiate a breath and you just kind of give them a little bit of support each time they initiate. And you can target an end tidal. And so if their end tidal is dropping and you think it's not a cardiac output thing, but more they're just breathing too fast thing, then you can not support every other breath.
Okay.
And I think that's reasonable to do, just because I appreciate there's one medic out there and you can only do so many things. And so you can put them on the SAVE 2 for 45 minutes and you can hand ventilate them for a little while. If you have somebody else around, you can hand ventilate them for a little while in between.
Okay. At least a fairly common scenario I'm running into, as of late, is I got a trauma patient and he's just starting to run out of gas. SpO2 starts dropping. We're doing resuscitation. We've done March, obviously. And it comes to a point where we're not improving just by resuscitation. We have the airway. SpO2s are falling. We now need to start doing vent management. And that's when I'm starting to initiate with the BVM and things like that, PEEP valves, etc. For that patient, am I just wasting my time going to the save 2 vent?
I guess you have blood gas capability.
I have no blood gas, but I do have a high-speed EMMA.
Yeah. It's just going to be that patient that you're describing is going to have high minute ventilation needs, and you're not going to be able to meet that with the SAVE 2. And so they're going to get worsening acidosis and worsening hypercarbia with the SAVE 2.
Okay. So just stick with the BVM.
If you have other things to do, I think it's reasonable to, again, intersperse the short periods of the SAVE 2 while you do another task. But I think that you give them a better minute ventilation with the BVM.
Okay.
Yeah. I mean, I think it's important to note that anesthesiologists and CRNAs can maintain a patient for an entire surgical case with good quality bagging, and you can, if you know what you're doing with a bag, you can actually do a really good job of taking care of a patient with ventilatory needs. It's just really super inconvenient and labor intensive. So remembering also that, especially when you're dealing with a limited device like the SAVE 2, it does get your hands free, but actually in many ways at the expense of significant capability.
Mm-hmm. Yep, I definitely agree. Either one of you, Josh or Evan, probably specifically Evan, since you're in charge of a number of medics, if there was anything that you would like to convey as far as paralytics go, what would that be?
I think the biggest thing that I'd want to convey is, I'm a big advocate for expanding the medic capability and making sure my guys have the ability to maximize their ability to care for a patient, and understanding that they may not have all of the resources that they'd like, so they have to really stretch things. I think that understanding that paralytics, whether you're talking about using them for RSI or whether you're talking about using them for ventilator management, they have an extraordinarily narrow application in either TCCC or PFC. And there's a lot of opportunity to go wrong with them, to hurt somebody with them. They're dangerous medications. And so I think that this should not be this is something that if one of my medics comes to me and says, hey doc, I'd like to use, deploy with paralytics, that's a conversation I'm willing to have with a specific patient for a given scenario. But I don't think that for any of the special operations medics that I'm working with is a standard capability. I think that's something that an individual medic with appropriate experience and training could be considered to use, but it's not something that just everybody should be able to have.
Josh, what do you have any advice?
Second what Evan said, and then just if you are going to be out there and put someone on neuromuscular blockade, make sure you sedate them heavily. And paralyzing someone to tolerate a vent that is not going to support their needs is not the right answer.
Yep. Foolhardy. Well, thank you guys very much.
Thank you, Dennis.
Thanks for having us.
All right.
It's been a pleasure.
That's it for today's podcast. Be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.